everybody there out in Cyberland. This is Melinda Flynn. Hope you can all hear me. You might be able to see me there in a tiny little thumbnail on your screen. I want to welcome you to our webinar today. And of course, I want to introduce our presenter, but before I do that, I want to just give you a little bit of information about what we're doing today. We have a 60-minute webinar scheduled, and so that will allow for some Q&A toward the end, the way I understand it. What I need everybody to do is to mute your phones. That is very important so that we do not have the background noise that comes from an unmuted phone. When it's time for Q&A, you are welcome to unmute your phone and ask questions via audio conference. But during the webinar, please keep your phones on mute. If you have any questions for me during the webinar, you're welcome to use the chat feature, which should be on your bottom right-hand part of your screen. You can also click the text box button up at the top there that shows text if you have any, or excuse me, chat, if you have any questions for me. But otherwise, I will not be on video. I will keep myself muted. But if you have questions, just give me a chat. And please, again, mute your phones while Dr. Campos-Outcolt is presenting. So I will go ahead and introduce Dr. Doug Campos-Outcolt. He is one of our esteemed faculty advisors. He is the chair and professor of the Department of Family, Community, and Preventative Medicine at the University of Arizona School of Medicine. And he is going to be giving us a presentation today on vaccines, which is obviously a topic near and dear to all of our hearts. So I'll turn over the mic to Dr. Campos-Outcolt. And again, welcome and thank you so much for being with us today, everyone, including our presenter. Thank you. Doug.
Melinda. Yeah, Doug, Campos-Outcolt. I'm with the College of Medicine here in Phoenix. We have several fellows with us in Arizona, and I'm very happy to be doing the presentation today. I'm covering the topic of vaccines, and we're going to be covering a number of different learning objectives, and they're listed here on the slide for you. We're going to start with one disease. We'll talk about that disease and how it was eradicated worldwide with the use of vaccines. We will then talk about a number of other vaccine-preventable diseases and talk about the morbidity and mortality that we no longer see in this country as a result of vaccines. We're going to talk about how vaccine recommendations are made, what the infrastructure is in the country to support getting vaccines to those who need them. And we'll also talk about vaccine safety and then the responsibilities of physicians in making the vaccine system work. All right, we're going to start with this one disease, smallpox. This is a disease which hopefully you will not see during your careers. You'll see why I said hopefully in the near future as we go through this presentation. Smallpox is an infectious disease that has killed more people throughout history than any other disease known. Those who survived smallpox in the past were usually left with very severe cosmetic deformities, scars and severe pitting of the skin. Oops, going the wrong way here. Okay, sorry. Now, this is a picture of one of the last persons in the world who had smallpox, and you can see the confluent lesions. And this is a very typical presentation of a severe form of smallpox. The natural history of smallpox is that it is spread through respiratory droplets and contact with the lesions. It does generally require close contact in order to get the disease. Historically, in the disease outbreaks, average one person will spread the disease to 7 others. Right. Now, this disease has historically been very, very important. It's actually changed the course of history. Here's some events that I've kind of just gone through and listed that were affected by smallpox outbreaks. Melinda, something's happening to the slides where they keep going back and forth without me changing them. I'm not sure what's going on with that. But
actually, you know what? There seems to be a little bit of a problem with the slides. My slides are not showing the same ones that you are, so I'm moving them forward. So for some reason, when you move them forward, not moving forward for the rest of us. So I'm going to actually do myself just to ensure that we're keeping up with you. I'm not sure what the issue is, but if that's okay with you, you just tell me which slide are you on number-wise.
I don't see a number, but the top 6. I'm sorry, yeah, it's 6.
Right, good. So I will just change slides with your talk if that's okay with you.
That's fine. I'll just tell you when I'm ready for a start.
Right. Terrific. Thank you. All right, I'll mute myself.
All right.
Keep going.
All right. Okay, so these are some historical events let's just start halfway down. When Europeans hit the Americas, both North and South America, smallpox was one of several infectious diseases that just decimated populations that had no exposure to it. Was a major factor in the Revolutionary War between the colonies and England, and it was a major factor in the westward expansion of European culture across what is now the United States, but is also other parts of the Americas as well. Native peoples in the Americas had no exposure to smallpox prior to their encounter with Europeans. They had no immunity that had evolved, and they had fatality rates when struck by smallpox of 90% or higher. Next slide. This slide kind of illustrates the evolutionary history of smallpox, in that if you're a population that's grown up exposed to smallpox, every so often there'll be an epidemic that'll go through. The mortality rate is a lot lower than if you're what we call a virgin population with no evolutionary exposure to the disease. So for instance, at the time of the Revolutionary War, Europe was heavily populated. They had smallpox epidemics every 5 to 10 years. If you survived to adulthood in those countries, you were immune to smallpox because you had it. In what was the colonies, the American colonies, however, the epidemics were much less frequent, and many of the adults who reached adulthood, those who reached adulthood in the colonies, had not been exposed to smallpox. You tell this by the fact that they have these scars I mentioned. Next slide. So we know historically that there have been attempts to control the disease, some surprisingly sophisticated, including variolization. And what that means is that a person with smallpox, that someone will scrape off one of the pustules and then poke the pus from the pustule into the skin of someone else to vaccinate them, essentially. But an unattenuated form of the virus, and it has to do that while if you survive it, which it does have a 1% mortality rate, that procedure, if you survive it, then you're immune to smallpox. And populations figured this out a long time ago, that this could be done. However, it does contribute to the spread of the infection, and it's a very controversial procedure. Interestingly enough, George Washington used this procedure to enhance immunity among the revolutionary troops, because he was afraid the British were going to try to use biological warfare against the colonial troops. Next slide, please. So vaccination is credited to Edward Jenner. In the late 1700s, he discovered that women who worked as milk maidens, meaning they milked cows, did have smallpox deformities, had no scars. He asked them about this, and they said, well, their hands were infected with cowpox, and that almost all of them had cowpox. And so he actually conducted an experiment with his own children where he inoculated them with cowpox virus and exposed them to smallpox. How he got his wife to agree to this is a mystery, but and of course there were no IRBs and human subject committees and stuff in those days, but that experiment was successful, and from that point forward, populations began to use smallpox virus to prevent smallpox. Thomas Jefferson was a very strong proponent of the procedure. Next slide. The problem with this use of cowpox, which, by the way, a variant of cowpox is the vaccinia virus, which is used in the vaccine today and was used in the vaccine throughout the 20th century. A protection it gives only lasts about 5 to 10 years. So that's a major problem with the vaccine. Next slide, please. I think we'll skip this one. It did play a role in the United States during the Civil War, but let's advance pretty quickly to the smallpox eradication program, which was started in 1967 by the World Health Organization, that was successful relatively quickly. The Western Hemisphere became smallpox-free relatively quickly. We stopped using the vaccine in the United States routinely, meaning recommending it for everybody, in 1971. We stopped vaccinating healthcare workers in 1976. And in 1977, the last naturally occurring case was discovered in Somalia. There were several accidental laboratory transmitted cases after that, but that was the last naturally occurring case. Next slide, please. After 3 years of no naturally occurring smallpox, the WHO declared the world free of smallpox. In 1982, vaccine was no longer required for international travel. In 1990, we stopped vaccinating military personnel. That was resumed in the 1900s, early 2000s, and particularly after 2001. And the U.S. military still inoculates using smallpox virus. And there were 2 repositories known left after the eradication, one at the CDC and one at a virology laboratory in the Soviet Union. Next slide, please. Smallpox has been used as a biological weapon throughout history. The British deliberately infected Native American tribes during the British and French wars in the 1700s. The Civil War was a time when both sides were suspicious that the other side would try to infect their troops with smallpox. There were experiments between World War I and World War II. The Japanese experimented on Chinese subjects with affecting them with smallpox virus. The potential as a biological weapon, however, at that time was pretty limited because there was pretty widespread use of the vaccine, so most people were immune. We know that the Soviet Union did mass produce smallpox virus in the 70s and 80s and did have it prepared to use as a biological weapon. That's a talk for another day. I just want to mention, though, that has led to concern to this day because we're not sure what has happened with all of that virus. Next slide, please. The vaccine. We're going to talk a little bit about that. If you get the vaccine within 3 to 4 days of exposure, it is effective in preventing the disease. It does have a very significant complication rate to it, though. The main figure you want to look at is that 1 to 30,000 serious illnesses, meaning that if you vaccinate 30,000 healthy people, one will have a very serious complication. A vaccine of this type could not get approved today. It just has too much complications to it. Next slide, please. It's administered intradermally by using a bifurcated needle. Poke needle into the arm. Between the 2 points on the needle, just the right amount of vaccine is contained. There's a specific way to poke it into the arm, and then the next slide will show us how done. We can proceed to the next slide. This lining up in the early part of the century to get their smallpox vaccine was done on the left shoulder. Next slide. And this is after getting the vaccine. This is the progression. How you can tell that the vaccine takes and will produce an immune response. It progresses from papules to pustules, scabs over, and then the scab falls off after about 3 weeks. Next slide. Complications, however, I mentioned, are severe in some people. Inadvertent auto-inoculation means you spread it from one site to another. If you touch that pustule and touch another part of your body, you can infect the other part of the body as well. And other people who are not vaccinated can inoculate themselves. That has happened in the military several times, where partners and spouses of military personnel inadvertently inoculate themselves with smallpox or vaccinia cowpox virus. All right, the other types of complications, I'm going to show you some of these in the next few slides. Next slide. This is what they call eczema vaccinatum. This is people who have eczema. The virus then spreads wherever the eczema has affected the skin. This is not a lethal complication, but a severe one, and a very unpleasant one. Next one. Generalized vaccinia. This basically, the virus gets into the bloodstream and spreads throughout. Again, not a fatal complication, but an unpleasant one. And you can see the large lesion under the baby's left arm there, and then spread through the blood system systemically, those leading to that rash across the body. Next slide, please. Progressive vaccinia. This is a fatal reaction. The vaccine inoculation site continues to just progress. If you look at the right shoulder on this patient is eaten away from the virus. In the vaccine, it's now progressing across underneath the neck and up the face. This will be a lethal response, usually in an immune-suppressed person. And currently there are some experimental antivirals that may stop this, but we really don't know because we haven't this kind of reaction because we haven't used the vaccine for a while. Next slide. To another disease. Okay, just to show you some of the issues involved with a very serious disease that was eradicated through the use of vaccines. And with the use of a vaccine, it has a fairly serious complications to it. But let's do another disease, measles. This child who has measles. It's a exanthem, and there are three symptoms that come with measles: cough, coryza, and conjunctivitis, meaning red eyes. So you get coryza, runny nose. If a child has those three symptoms plus a fever that then a day later turns into a rash, it should be measles until proven otherwise. Next slide. The most infectious microorganism that we know of. It is so infectious that if you enter into let's say a normal-sized classroom, and you have measles, and you cough or sneeze, that whole room will be considered infectious for the next 2 to 3 hours. And I've investigated measles epidemics where we have found people who have just passed each other in a shopping mall and have transmitted measles that way. It's a highly infectious agent. It's respiratorily transmitted to about 2 weeks from exposure to begin to develop the symptoms. Next slide, please. So there's a case definition I just mentioned: fever, one of the three Ds, and then rash. And if anybody in the United States is suspected of having measles, and it gets reported, which it should, to a public health department, then the public health department will confirm the case by doing serological confirmation for measles antibodies, now using measles IgM antibodies. Next slide, please. All right, annually before vaccines, so if we get back to the 1950s in the United States, we had millions of cases of measles each year. Vastly underreported. It caused hundreds of thousands of respiratory complications. Typical year, hospitalized 50,000 kids, caused 4,000 cases of encephalitis, resulting in permanent disability, and 500 deaths a year. That was an average year of morbidity and mortality from measles prior to vaccine. Next page, or next slide. Shows a graph where it shows that every 2 years we would have a worse epidemic because the number of susceptible kids would grow, Basically, everybody had measles by the time they were 2 or 3 years old. And then the first vaccine was licensed in 1963. There's a series of different vaccines licensed over the years, but basically as of 1963, vaccine became widely used. You can see what happened to the incidence of the disease, dropped down markedly and has stayed down, although we've had a few outbreaks that you can see. Let me just see if I can get my little here. You can see these little outbreaks right here and there and there. So we've had some outbreaks periodically, but the height of the outbreaks are nowhere near what they were during the pre-vaccine stage. Next slide, please. This shows the history of measles vaccine. The first vaccine, 63. Live attenuated virus, 65. Using the virus in 67. We had in 1971 mumps, measles, and rubella combined into a single vaccine, and we went to a 2-dose schedule in 1989 after one of those outbreaks where I showed you that last blip that went up. We discovered that you need 2 doses to get a high enough immunity level in the population. Next slide. There's a problem internationally currently. This is the number of cases that occur internationally. You can see Africa, that's probably underreported. There are probably hundreds of thousands of cases. And around the world, there are still large numbers of cases of measles, all declining because the world is becoming increasingly vaccinated. Next slide. The number of measles deaths worldwide, you can see going down year to year, and hopefully there'll be a time when we can declare measles eradicated. Next. All right, so your diseases I'm going to talk about here. Polio. This is a poster child for the polio campaign of the 1950s. The other slides show examples of people who have suffered polio. These types of people, these types of deformities are seen now much less often than in the past. I've traveled internationally for 50 years, and when I first started doing international public health programs, you would see these types of unfortunate people who had suffered polio quite frequently. And anymore, you just, particularly in the Americas, North and South America, you don't see it very much, and it's becoming much rarer around the world as well. Next slide. Polio still exists, however, in a few countries, and Nigeria being the one where we was the last. We got down to actually Africa, just one country left, and unfortunately, an anti-vaccination movement developed there, and people stopped having their children vaccinated, and there was a resurgence of polio. This shows cases from around the country, and it spread to other African countries from there. So we now have about 5 or 6 countries in Africa that still have endemic polio. That plus India, Pakistan, and Afghanistan are the only countries where polio still exists. And India is on the verge of having no polio. Next. Next slide, please. There we go. This shows you in the United States, and this is a log scale. Keep that in mind. So you go from 10 to 1, 100,000, and then down to 0.1 per 100,000. So it's a logarithmic scale, and it shows you the same thing that that I showed you before on the other slide, which is you start entering the vaccine, the number of cases come down. And this is for polio. So the previous slide was for measles. Exact same phenomena happened with polio. Next slide. Kind of shows the countries as of a couple of years ago that still had polio. And those arrows showed where out of Nigeria, other countries had polio reintroduced into them as a result of that movement inside Nigeria, which encouraged people not to be vaccinated. Next. Let's move rubella. This is German measles. Rubella epidemics in the United States would not occur as frequently as measles, but they occurred every 4 to 5 years. with millions of cases of rubella, and it causes encephalitis in a small proportion, but when you look at a public health perspective, that turns out to be a large number of people. It would cause, in a typical year, 11,000 miscarriages and 20,000 cases of congenital rubella syndrome, which resulted in deafness about half the time. Congenital rubella syndrome was, prior to vaccine, the most common cause of congenital deafness in this country. And it was a very common cause of cognitive deficits among children also. This has all been eliminated through the use of vaccine, and we now have in the United States at most a couple of cases of congenital rubella each year. Next slide. Look again, graph showing introduction of vaccine and the marked reduction in number of rubella cases. Next slide, please. This is the third antigen that's in the mumps, measles, rubella vaccine, sorry. And again, we introduce the vaccine, mumps cases come down. This causes inflammation, swelling of the parotid glands. It also has complications to it, and one of the worst that occurs in males is orchitis, or swelling of the testicles, in a small but significant proportion of those who get mumps. Next slide. Pertussis, whooping cough, same type of phenomena. The difference here is that you don't see the rapid decline. You see a more subtle decline. And this is a disease that's turning out to be the hardest to get controlled. We still have pertussis, many cases than before vaccine, but we still have a lot of pertussis. We have outbreaks about every 5 to 7 years. It causes severe coughing and post-tussive emesis. It has a mortality rate of about 1 per 100 in young infants. Next page. All right, the table just shows you a comparison. 20th century annual, this is a mean morbidity from various diseases that we now prevent with vaccines. Under the 2005 column, you'll see that most of these diseases are now either don't occur in the United States at all or are very rare. This is true for smallpox we've discussed, but diphtheria, measles, mumps. We talked about pertussis. We still have quite a few pertussis cases, but not nearly the number we had before vaccine. Polio, rubella, congenital rubella syndrome, tetanus, Haemophilus influenza. That's a bacteria that causes meningitis. When in training back in the 1970s and 1980s, we would have 1 to 2 children per week come in with meningitis due to Haemophilus influenza. We now see very few cases of this. Most physicians in training now will see only a handful of Haemophilus influenza cases while they're in their training. This causes significant numbers of children who have the disease to have post-infection sequelae, which can include neurological deficits as well as cognitive deficits following the infection. This has all been reduced significantly because of vaccine. Next slide, please. Vaccine preventable diseases showing the same data: hepatitis A, hepatitis B, pneumococcal. Now, pneumococcal invasive disease, we've only vaccines for the conjugated vaccines and for children for less than a decade, and we are making huge improvements in this disease as well. But there are still a fair number of cases because it's a relatively new vaccine. Varicella or chickenpox. We have made reductions in that, and what is to be seen on that one, which is at the moment, is if we prevent chickenpox, do we prevent shingles? My suspicion, and I'm sorry, just talked. I'm not sure if you're trying to ask the questions. We'll have time for questions at the end. We don't know that for sure, but my suspicion is we're going to have a lot less shingles as time goes on, because the shingles is as a result of natural infection with varicella virus. The virus then hides in nerves and then reactivates later in life along a nerve root that causes shingles. I think the virus, which is the modified live virus, will do that, but we'll see. We don't know that for sure yet. Next slide. We have some morbidity and mortality, particularly from flu. We have vaccines against flu, but we still have large numbers of flu cases every year for two reasons, which is the flu vaccine is less effective than we would like for it to be. The effectiveness varies year to year based on the strains, and because we don't vaccinate a very large proportion of the population. Next slide. All right, list of vaccines and the years that they were licensed. And of course, smallpox vaccine wasn't licensed in 1778, but it was starting to be used then. We didn't have a mechanism for licensing products until the early 1900s when we formed the Food and Drug Administration. You can see it's quite a litany of vaccines, and there are a number of vaccines still in production. Next slide. The routine school immunization schedule in 1983. This is the year I came out of residency and started practice. And to see it's not very many vaccines on there. We had DPT, which is diphtheria, tetanus, pertussis, and OPV, which is oral poliovirus. So those are 4 diseases we vaccinated against, and then we have MMR, 3 more. So a total of 7 diseases, not many shots, pretty easy schedule to remember. Next slide. So this is the vaccine schedule today. Many more vaccines on it, many more shots, complicated schedule, a lot more protection, a lot more diseases do we prevent, but that comes, with complicated schedule and a lot more shots. Next slide, please. Here's the schedule for adolescents. We now have several vaccines which are recommended for adolescents, including Tdap, which is tetanus, diphtheria, acellular pertussis, human papillomavirus, meningococcal, that causes meningococcal meningitis, and flu. The other things on there are high-risk groups or under special circumstances. But we have vaccines now which are recommended to be used routinely in adolescents. Next slide, please. This is the schedule. We have as many vaccines for adults. The numbers are growing. Flu, Tdap, varicella if you weren't immunized as a child, human papillomavirus vaccine up to 26 years of age, and then some other catch-up vaccines and those for certain groups, high-risk groups. If somebody just came on, would you please mute your phone? We don't hear the background noise. Thank you. Next slide, please. So we have now, in 1990, we had 16 vaccines. And in 2009, we had 60. And all these vaccines are monitored for safety. It gets more complex to do because of the number of products. Next. Slide. There we go. So what's happening with vaccines, in the trends in vaccines? Well, we now have vaccines against cancer, and we're going to have more of those. We have hepatitis B virus vaccine, prevents hepatocellular cancer, we think. And human papillomavirus vaccine, which prevents cervical cancer. And again, we think, because we have data showing that it prevents precancerous lesions, that proving or not that it prevents cervical cancer is still a few years off. But we believe that it is going to be a very effective prevention for cervical cancer caused by the types of human papillomavirus that are in the vaccine, which is 16 and 18. We are more combination vaccines, meaning more antigens per shot to try to decrease the number of what they call jabs or pokes. We've gone to annual influenza vaccine recommendation for everybody, and we're getting more non-injectable vaccines, meaning oral for the most part, or nasal spray. So we have nasal spray influenza vaccine, we have oral rotavirus vaccine, and we're going to have more of these in the future, and again, to try to decrease the number of injections that are needed. Next slide, please. So what's the big deal then? If these products are so effective and we're preventing all this morbidity and mortality, and believe me, The world is a completely different place. This country is a completely different place than it is today than if it would be if we did not have vaccines. And they're just diseases that cause significant morbidity and mortality that we just don't see anymore. But because we don't see them, the public and, in fact, many health professionals don't appreciate what vaccines have achieved. They just don't see the diseases that are prevented. And when you don't see them, you don't appreciate them. We are now developing vaccines for rarer infections, meningococcal meningitis, for example. That's a very serious disease, 20% mortality rate, and it's rare. The rate of diseases in the highest risk populations is about 1 per 100,000. It's not the 100% infection rates that measles, mumps, and rubella were prior to vaccine. We have school immunization requirements, and those are unpopular. People don't like being told they have to do things. So any kind of a government mandate is not popular. The cost-benefit analyses of vaccines, because they are rarer diseases and the vaccines are more expensive, the cost-benefit analyses are not as good as they used to be. The total cost of all vaccines is becoming an issue because of all the vaccines that we provide. We provide funding for children through the Vaccine for Children's program. If you're a child who does not have health insurance or have health insurance that does not cover vaccines, the federal government pays for your vaccine through the Vaccine for Children's program. The funding is a little less secure. Next slide, please. So vaccine safety has now become the big issue. When you don't see the diseases that you're preventing, you begin to ask the question, if there's no disease out there, why are we being vaccinated against it? The answer, of course, is, well, if you don't vaccinate against it, the diseases will recur. And people then say, well, but the risk of the vaccine may be worse than the risk of the disease. That actually is true if you don't consider that the infection issue if too many people become vaccinated. It's a matter of herd immunity. If that breaks down, we will have these diseases return. Because of these dynamics, safety is now the issue, and vaccine safety is in the minds of many parents when they have their children vaccinated. Next page. We do know that vaccines do cause some adverse reactions. The most common being redness and swelling at the site of injection, which if you have several sites of injection, you'll have several potential sites for redness and swelling. They can cause pain at the site of the injection and fever. Those are common adverse reactions, meaning more than 1 in 100. So, and in fact, swelling and redness at the site of injection is probably more in the 30-40% range. Common reactions can include some severe ones, and you can see the column, the table that's on this slide. They aren't very common, however. Next slide. So we know that some, like fainting or collapse after a vaccine, is in the 1 to 1,000 range. That happens in teenagers at higher rates than other age groups. A seizure from a vaccine-caused fever, a febrile seizure, that occurs with some vaccines at the rate of about 1 per 1,000. What happens at a rate of 1 per 1,000? Hit your next slide advancement. I think we'll have something pop up in that. Chances of having quadruplets. Okay. A serious allergic reaction to a vaccine can occur at the rate of about 1 per 100,000. What happens at a rate of about 100,000? Hit the next slide, please, and we'll see something come up in that. Getting struck by lightning. Less than 1 million, you can have some really severe reactions. You have about the same chance of winning the lottery. Now, I don't want to make light of these reactions. They do occur, but I do want to put them in context. That they're not very common, but they do occur. Next slide, please. Here's the federal system that's been set up to monitor vaccine safety, and I want to walk you through this. The Department of Human Services, right here, this is the Federal Department of Health. They have a National Vaccine Advisory Committee, right here, a National Vaccine Program Office in DHHS. Then there's Vaccine Safety Group. There are 3 different organizations that are involved with vaccine safety. The CDC, through the Advisory Committee on Immunization Practices, right here, monitors vaccine safety in collaboration with the FDA over here. And they have a division that's involved with monitoring vaccine safety. Then I'm going to talk about this, the Health Resources and Services Administration and their role in vaccine safety in a moment. Next page. All right, is a system for reporting suspected adverse events. It's called the Vaccine Adverse Event Reporting System. This is operated jointly by the CDC and the FDA. It's a passive surveillance system. In other words, they wait for calls to come in. There are thousands of reports every year, and those are monitored to see if there are any trends in them. But because it's a passive system, it is subject to underreporting. Not all vaccine reactions get in there. We know that. However, it's also subject to overreporting. People who something happened because of a vaccine, when in fact it wasn't the vaccine that caused it at all, these things do get reported to VAERS. What happens after when there's a suspicious trend, then we start using the Vaccine Data Link project, which is a collaboration between the CDC and 8 managed care organizations around the country involving 8.8 million people, and test hypotheses using electronically linked data to see whether if any of these suspected adverse events are in fact happening at higher rates in vaccinated versus unvaccinated populations. Next slide, please. I've already described the VAERS system. We can go to the next slide. This is the number of vaccines distributed in the country in hundreds of millions of doses. We estimate that in this country hundreds of millions of vaccines every year. Next slide. And we get thousands of reports on VAERS. Most of them are not serious. Some are serious but not fatal, and then there are some deaths that are reported, and these are investigated to see if there's suspicion that the death was related to the vaccine. Next page. That's an example of how this system worked. Back in the late 1990s, the first rotavirus vaccine was called RotaShield, and it was licensed. The recommendation was to use it universally. We started receiving reports of intussusception, which is a potentially life-threatening intestinal obstruction. And I'm sure you will find out what intussusception is at some point in time during your training. But as a result of this VAERS reporting and a study that was done, it was confirmed that 1 to 2 per 10,000 children vaccinated were getting intussusception, which was a much higher rate than should be occurring based on the natural occurrence rate. And the product was removed from the market. Next slide, please. Showing you where the Vaccine Safety Data Link sites are located across the country. Next slide, please. Next, there you go. This is a number of events that have occurred over time where a product has been modified or changed because of findings in the vaccine safety monitoring system. We went from a non-acellular to acellular pertussis product because it is a safer product. We went from oral poliovirus to inactivated poliovirus because of 5 to 6 cases of polio that were caused every year from the vaccine, from the OPV, but that does not occur with the IPV product. 99, I mentioned with the RotaShield issue, and in 2008 we discovered that a new combination vaccine caused higher rates of febrile seizures than separate vaccines that gave you the same antigens, and this was publicized, although the product was not felt to be serious of a complication to take the product off the market. Next. The vaccine Injury Compensation Program was specifically set up to compensate anyone injured by being administered a childhood vaccine. Next slide, please. It's administered by the Department of Health. That's the Health Resources and Service Administration program I mentioned before. It's a no-fault system, meaning that if you have an adverse reaction from a vaccine, it's not caused by the vaccine. You apply for compensation, you will be compensated. And this is funded by a tax. I think it's $1 or $2 per antigen. There are hundreds of millions of dollars excess in this fund, and it is sitting there waiting to compensate. And they just don't compensate very many people because vaccine reactions are so rare. The burden of proof is less than the normal liability system. If the vaccine reaction is, or a reaction is not known to be caused by a vaccine, but there's reasonable to think that it was or might have been, compensation occurs. It's a very good system, a highly successful system. It was implemented because vaccine manufacturers were dropped out of the producing vaccines for fear of liability. And this program has basically saved our vaccine system. We now have many more producers coming into the producing vaccines, and anybody who does suffer a serious adverse reaction, they will be compensated. It's a very generous compensation, and it's a system that's meant for ease of use. Everybody who has gone through it likes it, of course, except for those who don't get a favorable ruling. Next. System. There you go. So here's some facts about this system. I'm going to scoot on because I want to get to questions here, so we'll skip this slide and let you just look at it at your own leisure to see that. So we've talked about the Advisory Committee on Immunization Practices. This is a group that meets at CDC 3 times a year, works by teleconference between calls, considers new vaccines, and makes recommendations as to their use. The group also monitors vaccine safety and potential reactions and makes determinations on that also. I have the privilege of serving on the Advisory Committee on Immunization Practices currently. I was picked to be on the committee starting last year. I've served my first year. I have 3 more years to go. And prior to that, I was a liaison to the ACIP for 5 years. So I've watched this group work a number of years now, I suppose that's also a potential conflict of interest on my part, which you should know about, is that I do serve on this committee. Next slide, please. What's the physician's role in the vaccine system? It's as follows. You should provide vaccines in your practices. You should stay current on vaccine recommendations. You should recommend to your patients to be vaccinated. If you suspect an adverse event has occurred as a result of a vaccine, you should report it. You should provide accurate information to the patients about the potential benefits and harms of vaccines so that they can make good choices. You should refer them to trusted websites. Unfortunately, as with everything on the web, there's a number of inaccurate and highly inflammatory websites out there, but you can steer people to websites, and I have some of those attached as a slide at the end of the presentation. I think I'm going to stop now and open it up for questions. There are some more slides there that you can go through later, which kind of talk about a little bit more about some of the issues we've mentioned here, but I think I'll stop at the moment. Let's just call in. If you have a question, you can call in, and Melinda will serve the gatekeeper for the calls.
Lisa, that means that you should mute your phones. Unmute your phone if you have a question. Just unmute and start speaking. If you have any trouble with that, just send me a chat. I don't know if everybody can hear me. I have a chat question.
Okay.
I actually have a chat question for you. Dr. Anthos called. I'm just going to read it to you.
Okay.
Have any individuals been compensated concerning vaccines and autism, or the court rulings negative connection and therefore compensation. So did you understand that?
I did, yeah, and it's an
Okay.
excellent question, and actually that is a topic I would have covered had I continued in the talk. There were hundreds of claims before the vaccine courts regarding autism. The courts divided the claims into three different theories, and I won't go into the details, but they held three different hearings on those three different theories, and in each case, they determined that there was no evidence of causation. So those there has been no compensation to, and there's one exception, which I'll get to in a minute, but the claims of autism, either because of Marisol or mumps, measles, rubella vaccine or a combination, those were rejected by the courts, meaning that the courts found no valid evidence for them. They're rather strong in their statements because that was such a hot topic. It's a very interesting reading if you go through the court and read the hearings. But basically came out and said that the medical experts that the plaintiffs had were misleading them. And they felt a lot of sympathy for the plaintiffs, but that the science just did not support a causation. One exception to this was one child who had a mitochondrial chromosomal or mitochondrial DNA disorder. The child received some vaccines, had a very severe reaction, developed autism. Really don't know whether that was caused by the vaccines or what happened anyway. A single case is really hard to go from, but as per the court's methodology and their philosophy, they compensated. They said, "No, we don't really know on this particular one, but we're going to," and those parents received very generous compensation for that, even though we didn't know whether the vaccine caused it or not.
Terrific. Additional questions, and you may not see them on your screen, Dr. Campos Outcolt, so I will read them for you. There's a question from. Okay, for me to read them? Okay, terrific. One is, I have a question for the presenter. Why are HPV vaccines only recommended for women up to age 26?
Okay, I know. Well, first of all, they're recommended for men and women. Women through 26, men through 21, and they're high risk, meaning men who have sex with men or immunosuppressed, and then that's through 26 as well. The reason is because the studies for licensure went through age 26. One of the manufacturers recently submitted to FDA to have that age raised, but the FDA did not approve it, and they didn't for the following reason. The epidemiology of HPV infection is such that women after age 26, they've either been infected, they've probably been infected before, and so the amount, and once infected with those types, the vaccine doesn't help you. So the amount of protection that offered to a woman over the age of 26 is very low. And however, there are some women who could potentially benefit. If a woman has had no sexual contact up through age 26 and has never been vaccinated, technically you could get protection from the vaccine. It's not illegal to use it. It's off-label. You can vaccinate a 27, 28-year-old under those circumstances where they, and I frankly would consider doing that in those circumstances. But it would be off-label use of the vaccine. And for the coverage through insurance and stuff might be an issue as well. But that's the reason for that.
Terrific. I have another question. What are your thoughts on the possibility of an HIV vaccine? Should we focus on vaccination or prevention of transmission?
Okay. Well, there will be an HIV vaccine someday. How soon is anybody's guess? If I were a betting person, I would say it will be within the next 10 years. Should we concentrate on the vaccine versus transmission? Well, you concentrate on both. But say, frankly, that I think our educational efforts to prevent transmission have been a dismal failure. We have 30 to 40,000 cases of HIV in this country every year transmitted, and it's not a particularly easy disease to get. It's not as infectious as hepatitis B virus or has measles or any of those others. But we have about 30,000 new cases per year. So while I do think educational efforts to prevent transmission have some effect, I don't think it's large. And I think the only way this disease is going to be brought under control is with a vaccine.
I have another question from one of our attendees. The attendee is curious about what you think about the movement of parents refusing vaccines for their school-aged children. There seems to be many of these in elementary schools right now.
Yes, that's right. And it does appear to be a growing movement. Getting a good estimate of numbers is somewhat difficult, and it does vary by geographic region and social networks. So there are some social networks where this is approaches 100%. Society-wide, I think it's in the 10 to 15% range. And I think it's to be expected. When you see the diseases, you're worried about vaccine safety, particularly when there's a lot of inaccurate information out there about vaccine safety. The natural response is for people to be hesitant to vaccinate. The pandemic will solve that problem, and this will happen. As soon as our immunization rates get below a certain level, we'll start having measles outbreaks. Hopefully, we won't have a resurgence of polio, but measles, rubella, kinds of diseases, they will come back. Then the society's attitudes will switch. So it's just, it's kind of a natural cycle. It does happen. It's not a new phenomena, by the way. There have always been anti-vaccinationists out there. The smallpox vaccine program in this country in the early 19s had a very significant anti-immunizationist movement against it. And actually, that had a lot more rationale to it because that vaccine that was used in the early parts of the 1900s in the United States had serious side effects, was produced under nearly the controls and standards that vaccines are produced under today. And frankly, I probably wouldn't have, knowing what I know today, had I lived then and known it, I wouldn't have taken the vaccine either. But that's an entirely different matter. So anti-vaccination sentiment is not new. It comes in cycles like everything else. As soon as we have, and I'm not saying if, I'm saying when, as soon as we have a very serious pandemic in this country with a disease that's prevented by vaccine, most of that opposition will dissipate. Does
anybody else have questions for the doctor this morning?
I have a question. I was wanting to know if there are any vaccines that still have mercury and preservatives in them.
The mercury was in some vaccines is thimerosal, and thimerosal has been taken out of all vaccine products except for really, really small amounts of residual. It's one exception, and that's multi-dose vials of influenza vaccine, and that has a dose of, and I cannot remember whether it's ethylmercury or methylmercury. There's two forms of mercury. One's methylmercury, one's ethyl. The that is in the environment that does stay around in tissues longer is one form. The form used in the vaccine is the other, and it just doesn't stay in the human body for a very long period of time. The only vaccines remaining are multi-dose vials of influenza vaccine.
Terrific. Another question that was typed out for us. It says, can you speak a little about dry vaccines? For example, the use of tartrates in dry vaccine technologies in order to bring vaccines to places that may not have access to refrigeration but which have a need.
That's an excellent question, and it's one that's a little bit beyond my expertise. I do know a lot of development work going on, try to find vaccine products that can have a wider use without a cold chain. But what they are and how far along the technology is and so forth, I'm sorry, I just am not able to answer that question. I just don't know.
Okay. Any other questions? I have a question,
Okay.
if you don't mind.
Last question. Yeah, we're
terrific. My question, I'm sorry, there's some ambient noise here, but my question actually has to do with a clinical practice issue, I believe. Had a colleague mention to me that they were very uncomfortable with their physician having offered the HPV vaccine to their probably 11-year-old aged child. And they said to me, oh, this is a sexually transmitted disease. Why is my child being vaccinated for this? And I was curious, you know, to the shoes of the physician, what would be the response that you would suggest, you know, clinically that could be given to that parent to reassure them about, you know, why their child is getting an STD vaccination, quote unquote?
Okay. Yeah, it actually is very easy to address. In that we're not accusing the child of anything or doing anything. We're protecting the child for the future. That once a person starts sexual activity, and by the age of 18, that is well over 50% of both males and females, that within a very short time, over half are infected with HPV virus of some type. Not necessarily the types in the vaccine. And then, you know, one of these groups that was, you know, very religiously oriented stood up at CDC when the vaccine was being promoted, and they said, you know, we're accused of being against this vaccine for this reason, but we're not, because women can be raped, can marry bad men, she said. I was kind of taken by that. But, you know, you know about the man you're marrying, you know. So it's protection for the future. And we have other vaccines against sexually transmitted diseases. Hepatitis A virus can be sexually transmitted. Hepatitis B virus can be sexually transmitted. How come nobody's asking about these? So, you know, we just protect people against diseases they're likely to be exposed to in the future. And it's a cause of cervical cancer. So, you know, I don't want to be a parent. I wouldn't be a parent down the road to have a female come back to me and say, you know, I've had an abnormal pap smear. I now have to undergo colposcopy, possible LEEP and other treatments, or worse yet, I have cervical cancer. They could have prevented as a parent, and you didn't.
Thank you for that answer. I think that we're pretty much at the conclusion of our time slot. I want to thank, obviously, Dr. Doug Campos-Outholt for his really fantastic presentation today. I also want to thank our attendees who were able to join us today. Thank you very much for being with us today and asking such great questions. And this will be available within a few days in the recorded format, and I will email everybody who was originally invited so that they come back and view the full recording and, of course, look at the PowerPoint presentation as well. But again, thank you very much. I will end the webinar now, and I hope everyone has a wonderful afternoon. Thank you.